Welcome everyone to tonight's live Q&A discussion. This is our third Brain Translate Q&A event, but the first featuring members of our epilepsy group. While you can't see me this evening, my name is Eric and I'll be helping moderate tonight's discussion from behind the camera. I co-run a science communication initiative called MS Translate, and we've been collaborating with the Melbourne Brain Centre to bring these Brain Translate events to you. Tonight, as you can see, we're lucky to be joined by three members of our epilepsy group. We have Dr. Jijun Chang, Dr. Chris French, and Miss Lucy Vivash. In a moment, I will hand over to the team to introduce themselves, providing a brief insight into their background and the work they do here as part of the epilepsy group. Then we will begin to pose a range of questions received during the week, some of which are general, and others which are more specifically focused on the research we've been covering throughout the event. However, I should also mention that those watching us live on YouTube or through Google+ can also submit questions during the broadcast, and we will do our best to answer them while on air. Any that can't be covered tonight will be followed up in the coming days, and questions can be posted on either the Melbourne Brain Centre RMH Facebook page, on our Brain Translate website forum, or via email at info@braintranslate.org.au. I will be monitoring those platforms and will do my best to cover as many as I can when they come through. Now let's get started, and I might hand over to Dr. Chris French to begin the introductions.
Thanks. So I'm a neurologist at the Royal Melbourne Hospital, and my subspecialty of interest is epilepsy. And in addition to that, I run a laboratory at the Melbourne Brain Centre looking at fundamental mechanisms of neural activity and the effects of anti-epileptic drugs on neural systems.
So, hi, I'm Lucy Vivash. I'm a postdoctoral fellow looking at brain imaging techniques in epilepsy and other neurological disorders.
Hi, I'm JX or Jin Chan. So I'm a researcher at the Department of Medicine, now here at the Royal Melbourne Hospital under the University of Melbourne. So I'm a basic scientist by training, and one project I run is on a mouse model of both Alzheimer's and epilepsy. And we're also having a project for developing point of care devices for the test for drug hypersensitivity for anti-epileptic drugs.
Okay, thank you everyone. We'll begin by starting to go through, as I said in my intro, a series of questions which have been compiled throughout the week. We might start with a few general ones to get started that can be answered by any member of the team. The first one we've got here is, what are the risk factors for epilepsy?
Do you want to start being neurologist, Dr. French?
So, well, there's several risk factors. They're quite variable. So we can divide epilepsies up into two basic types. There are focal epilepsies and generalized epilepsies. Focal epilepsies are where there's an abnormal part of the brain that's abnormally active and that results in seizures. And they are sometimes as a result of trauma or any other type of lesion in the brain, for example, a brain tumour, or else hemorrhage, or etc. Then there are other types of epilepsies called the generalized epilepsies, and they are frequently on the base have a genetic basis. We don't always know exactly what gene is involved, but they tend to comprise about 20% of all epilepsies. So there are quite a few ways to divide up the types of epilepsies and what predisposes you to them, but they're a good general breakdown. In addition to that, some other risk factors are if you've had around birth, for example, if there have been some abnormalities, either excessively premature or delayed in delivery. And then another factor that we are paying a lot of attention to is febrile convulsions as a child, especially in that first year or 18 months of life. Having repeated convulsions in the context of fever can sometimes predispose you to having seizures later on. Another interesting factor that is not so well known is that age is a predisposing factor for epilepsy. We tend to think of epilepsy as being a problem of younger people, which definitely there is a major spike in the incidence of the problem in those younger age groups. But we find over age 70 there is another major increase in the rate of epilepsy occurring. So there are quite a few other risk factors that I could talk about, but I think this covers the general pattern pretty well. Any other?
I mean, there's just the traumatic brain injury kind of thing, with lots of car crashes and repeated concussions, that kind of thing. Post-stroke.
Absolutely.
Just bleeding.
Sort of structural abnormalities, secondary structural.
Okay. Speaking of risk factors, the next question we have here is epilepsy a risk factor for any other diseases?
Yes and no. Epilepsy is often found to co-occur with anxiety and depression. I think it's about 30% of patients with epilepsy have depression as well, which is something which is not just because they have epilepsy and they're sad about being diagnosed, but something separate from that. And there may or may not be shared mechanisms that cause these two diseases. Nothing else really.
And I think there's also like, I'm not sure whether it's a risk factor for other disease, but we do know that let's say Alzheimer's, so people with Alzheimer's actually is 10 times more likely to get epilepsy compared to the age-matched other group of people. So whether it's Alzheimer's that's driving the epilepsy or the epilepsy driving the Alzheimer's is still something like controversy, and still lots of things needs to be researched and studied on.
Yeah, and I think that's some of the people watching us this evening may have seen your video featured yesterday.
Yes.
Which explains the research you're doing in that area in
Yes.
a bit more detail. So if people haven't seen that video yet, they can certainly go to the Brain Translate YouTube channel and watch that video in full there. Moving on to the next question that came through, we've got, are there drugs used for other pathologies that could be used to help epilepsy?
Yes, well, probably the more common situation is that drugs that we use for epilepsy tend to be useful for a lot of other things we're finding out as time goes on. So I might just address that first. For example, valproic acid, which is otherwise commercially, one of its commercial names is Epilum, has been used for many years, especially for the genetic or the generalized epilepsies, and it's also quite good for focal epilepsies, but it's been found to be extremely useful for bipolar disorder, and so it's one of the main drugs used these days for bipolar. In addition to that, for many years, some of the anti-epileptics, especially carbamazepine, otherwise known as Tegretol, is used for pain control in many situations, so especially for peripheral neuropathies and trigeminal neuralgia. So it's a very useful drug for that. Similarly with phenytoin, one of the archetypal anti-epileptic drugs has been used actually as an antiarrhythmic agent in the heart. So there are all these other applications that are extremely interesting and expanding all the time, actually. Having said that, there is one class of drug, the calcium channel antagonists, which are used mainly for hypertension, which potentially have a role in epilepsy, which I think is largely underexplored. Drugs such as verapamil. There are no clear clinical indications for use of these drugs, but from the basic pathophysiology of epilepsy being a hyperexcitable state and the role of calcium currents in that, it's actually certainly worth further investigation.
Okay. Just while we've been talking through that question, we've had a question come in over the internet from someone watching the broadcast. And it relates to the previous response by yourself, Dr. Chan, relating to the study looking at epilepsy and possible connections to Alzheimer's. And the person asks, can the spike in risk of epilepsy in older people be explained by increased rates of Alzheimer's as well?
Spike in rates of epilepsy. It's a good question. I think currently, it's more study has been done on Alzheimer's, and we see age with Alzheimer's having risk factors for epilepsy. But how even for that, how it works is still unknown, and no one knows what's the mechanism. So to answer the question, like if the spiking, is it a risk factor? We actually don't know the answer. It could be a risk factor. We never know because we involve this whole network different in the whole brain. That it's a quite complex issue. So we probably don't know the answer at the moment. But
I think it'd be important to say that while it'd certainly be a component of that increased rate of epilepsy in that age group, there are certainly people who get epilepsy in that age group just that so-called de novo without having a history previously, who do not have Alzheimer's disease. So certainly there is a definite component that is not related to the neurodegenerative disease.
Okay. Yeah, I think it's probably a very small proportion of people who have both, and they both can develop independently. So there will be a small amount of crossover, but it will not be that if you develop epilepsy when you're 17, you're going to get Alzheimer's, or vice versa. If you get Alzheimer's when you're 17, it's going to be compounded by also having epilepsy. There's, you have to have very bad luck to get both at the same time, which may or may not be something to do with the tau build-up, which is seen in both diseases.
Okay. All right. Well, thank you very much for the answer to that on-the-spot question, and thank you to the viewer for submitting it online. The next question we'll move to, how do most anti-epilepsy drugs work?
The golden question. No one really knows.
Okay.
So Chris does a lot of work in this field and has done for what, 20 years?
Oh no, not that long.
Not that long? All right, maybe 10 years.
Time flies when you're having fun.
It's fairly good effort considering you're only 25.
Oh, he's such a prodigy.
35. So, in general, it's fair to say that epilepsy, it's good to stand back and see what the problem is first, and then see what we know, and then more importantly, to see what we don't know. So with regard to drug effects, epilepsy is an abnormal synchronous firing of neurons. So your brain normally, to do anything, to move your hand, to talk, you have to have the firing of neurons. And they have to be firing in a particular sequenced way. But when that firing becomes hypersynchronous, when they start firing all at once, in an inappropriate fashion, then you get a seizure. And that may be a convulsive seizure where you're shaking because your muscles, the areas of your brain that control your muscles are all firing inappropriately. Or maybe some other part of the brain that is being activated inappropriately, and you have an absence or a complex partial seizure. So what do these drugs do? What does an anti-epileptic drug do? Well, there are certain drugs, for example, Epilum or valproic acid, a commercial name Epilum, where we actually have very little idea how it works, but it works well. You give an adequate dose, many persons with epilepsy will have the seizures controlled. There are several groups of drugs that we do have quite a lot of information about what they're doing, and we increase all the time we're getting more and more information. Those drugs are the ones of what we call the sodium channel modulators. So a sodium channel is the type of ion channel that makes the neurons to polarize or fire electrical pulses. The same channel is in your heart and your muscle, and also in the brain cells. And we know that drugs such as phenytoin reduce the amplitude of those currents and the ability of those currents to fire rapidly. So the typical drugs in those class are phenytoin, tegretol or carbamazepine, lamotrigine, and also topiramate are drugs of that class. So the actual effect on the sodium channel is probably adequate to explain how the drugs are working. Then other drugs probably affecting synaptic transmission. So, for example, a lot of benzodiazepine drugs like Valium, for example, are very effective anti-epileptic drugs. And they work by increasing the inhibition in the central nervous system, especially through the neurotransmitter called GABA, which is the primary inhibitory neurotransmitter, which is enhanced by these drugs. So they're two simple explanations that really conceptually give you an idea why seizures are being controlled. But working in the area in more detail, what we really need to understand is how the whole complex network of neurons, both excitatory and inhibitory neurons, are working in concert to become abnormal. And there may be other factors that we really don't have any handle on at the moment, how these drugs are working. So the message is we know a great deal about drugs that work, but there is still a huge amount that we don't know. And we really do not have a way of designing a drug that will work in epilepsy yet. That will be really the holy grail or the gold standard that we define such to get that knowledge.
And in addition to anti-epilepsy drugs, are there any surgical options that exist for epilepsy?
Yes, certainly. So, is that probably?
Oh, well, it very much depends on the kind of epilepsy that you have. People who have the generalized epilepsies that occur with absence seizures or generalized tonic-clonic seizures, there isn't a particular part of the brain that causes the seizures. It's a whole, like, network-wide involving all of your brain at the same time. So there's not an area that is specifically causing the seizure that you could disconnect from the rest of the network. So in that case, surgery isn't going to work. Just got to try your best with drugs. But for people who have a known lesion, so some kind of structural problem, whether it's a brain tumour or some other kind of structural abnormality like hippocampal sclerosis or a dysplasia, then what we can do is we can cut that part of the brain out and, in theory, improve their seizures. Some people come out of surgery and don't have seizures anymore. Some people can be controlled while staying on drugs after surgery. Other people will have a massive reduction in seizures. And for some people, unfortunately, it doesn't do very much. For some more kind of severe childhood epilepsies, there are other surgical options like just basically severing the two halves of the brain to stop the network interaction causing massive seizures, but that's something that is less of an option these days because it's seen as a bit severe for people to have to deal with.
Okay.
And then I suppose there's vagal stimulator.
Yeah, that's another area that would come under a surgical option, but using nerve stimulation, there's a technique called vagal nerve stimulation where some electrodes are put in to stimulate the vagal nerve, which, and then so that has to be, it's like a pacemaker being put in for your heart. You put in a subcutaneous stimulator, and that then stimulates the vagal nerve. And that is generally considered to be about as good as a drug, as an extra drug in terms of reducing seizure frequency.
Okay. And when an individual is diagnosed with epilepsy, how do you go about determining whether the best course of action for them is to go on to an anti-epilepsy drug or whether surgical intervention may be an option?
Well, first off, you'll try drugs because drugs are easy. Tell someone, oh yes, you've got epilepsy, try these drugs, see what happens. And you will always have a view to better defining what kind of epilepsy they have and whether or not further down the track surgery may be an option for them. So, when they first come in and they say, doctor, I think I've had a seizure, someone like Chris will ask them to describe it and get a bit of a history and try and figure out whether or not they have had a real seizure. And it's normally after 2 seizures you get the diagnosis of epilepsy, and then you may start medication. And then you'll just see how you go. It may be that the first drug works really well and you're controlled very well for the next 10 years with no problems whatsoever. Or it may be that you have very severe drug refractory epilepsy. So you go through, try 2 or 3 different drugs, doesn't work. And then you come in, excuse me, to see us at the EEG unit, and we have you in for a few days to really get to grips with exactly what's going on with your seizures, find out exactly where in the brain they are. And then we try and do some brain imaging at the same time, have an MRI to see if there's a structural lesion. that may be something that we can take out for surgery. And you might also have a PET scan or a SPECT scan, which are two ways of using a radioisotope to look at where the seizure focus is. So these can both inform exactly what part of the brain it is that's causing the seizures, and then you may go and cut that out. But honestly, if someone's well controlled on drugs, it's way easier for them to stay on drugs, because whilst surgery may stop their seizures, it may not. They may get it relieved, they may get a problem further down the line. It could exacerbate things. Whilst, most times surgery is fine, goes without a hitch, and will reduce people's seizures. There's always that risk. And if you don't want to, if you don't have to take the risk, it seems unnecessary to.
Fair enough.
That's exactly the case in 99% of cases. You occasionally see an exception where someone's, for example, got a meningioma or one of those benign brain tumours that tend to grow and are very epileptogenic. So if they have a seizure as a result of that, we tend to go to surgery very quickly. But apart from that, we will most often try drugs first. So those are often well tolerated and stop seizures.
Your attention, please. Okay. Could Dot Tran return to 9 East?
We'll move on to the next question. Are there any new genes that have been identified as major predictors of epilepsy or epilepsy severity? How long does it usually take for new genes to be incorporated into new screening methods in the clinic?
I think the group out at the Austin seem to come up with a new gene for epilepsy just about every week. They're very prolific in this area of identifying genes that are the cause of particular kinds of epilepsies, but as a major predictor, not really. I mean, the early studies looking at genetic causes of epilepsy really didn't find anything that stood out very strongly for a major cause of epilepsy that affects a lot of people. But yeah, there's definitely these little niche epilepsies that are very poorly understood that turn out to have a genetic basis, which the guys at the Austin are really into.
Yeah, I think, although having said that, there are many genes that cause, genetic abnormalities that cause epilepsy, and one of the confounding factors is that the same genetic abnormality can cause different types of epilepsy, which is very confusing. Having said, but there is still a sense, I think, that there may be some subtypes of epilepsy. There have more recently been some potassium channel abnormalities, these ion channels that conduct potassium and tend to have a stabilising effect on neuronal membranes that you have a sense might give you a different slant on therapy, but still that's very far from being demonstrated. And ideally the future is personalised medicine, where we would have a clear genetic fingerprint of what the epilepsy is caused by. We'd have a particular drugs strategy that would be best for that epilepsy. But so far that's not the case. Yes, so I think that's fair to say. And the work at the Austin and similar places where they're looking at these types of genetic epilepsies is really a fantastic effort. I think is already, it's shown a tremendous amount of, it's been immensely helpful in understanding some types of epilepsy. And then hopefully in the future will come.
Yeah, like just in that last point there, like how long does it take? I'd say from the initial discovery to being something that the general neurologist would look for, we'd probably be looking at 10 years from when it's first reported, because it has to be replicated a few times before they kind of go, yeah, this is real, this isn't just some aberration, and then getting it out to everyone else to go, no, if you think this person's got this kind of epilepsy, test for this.
Yeah, okay.
And it's quite a while.
Is the incorporation of genetic screening into this process, is it expensive? Is it something that's widely used at the moment? Will it become more prevalent in sort of the coming 5 years?
I think the cost has gone down considerably in the last 5 years and will only continue to decrease. So whilst cost is probably a bit of a consideration now, 10 years down the track, it really won't be. And JX is doing a lot of work in developing point of care and doing genetic screening, basically in the clinician's room, not having to send stuff away. And that's something that he's working on. So it's something that is definitely going to be a bigger part of the future, the whole personalised medicine thing.
Because
Growing.
So because currently most of the genetic screening we're doing, it's more for drug hypersensitivity. So for example, if certain people with certain genetic variant, HIV variant, they have really bad adverse reaction when they take certain drug like carbamazepine. So we identify that this particular HIV variant is definitely going to cause reaction. So it's like almost 100%. So we know. So we'll be developing ways to like a point of care device, so we can use it in the clinic and then test the patient at the clinic within an hour, and the cost will be like less than $10 per device. And then currently, if you want to do a screening, test for HIV variant for drugs hypersensitivity, you need to send it, take a blood sample and send it to a lab, and from the lab, then it takes about another 1 or 2 days to a technician and machine to get the particular HLA and send it back. So it takes about 1 week or 2, and it costs a few $100s. Yeah. So, but with more like point of care device that we're trying to make, in the end will reduce the cost by a lot, and cheap and faster too.
Okay. While we've been talking, there have been another couple of questions that have come in from people watching us. So I might you take the first one, which is directly linked to what we're talking about with the genetics of epilepsy. This person's asking, how strong is the genetic link? For example, does epilepsy run in families?
Well, it depends on the type of epilepsy. There are a few types of epilepsies that have conventional autosomal patterns, and autosomal recessive or dominant, but they're quite rare. Then, if you an average patient coming into the clinic, it is quite striking how often a family member will have a type of epilepsy as well. And sometimes it's a different type of epilepsy. It doesn't always follow exactly the same line. And then one of the lessons taught to me by one of the very senior epileptologists in Melbourne was that to take the family history very carefully. So most of us will say, oh, is there any epilepsy in the family? And people will go, no, a lot of the time. Or sometimes I say yes, but then it's always worth probing a lot more closely. Was there how well do you know your aunts and uncles and so forth? And often with closer investigation, I find that it's more common than one would have imagined. And it's exactly through that sort of asking, that simple history taking, and building up of maps of incidents in a family, that those first discoveries of the genetic links of the various types of epilepsy were made. So one question that gets asked to me by patients, not infrequently, is that I have epilepsy, or my son has epilepsy, or one of my family members has epilepsy. Are their children going to have epilepsy? It's something that worries them. And the answer to that is most of the time is almost certain, unless it's a very unusual type of epilepsy.
Okay, we'll move on to the next one. And this one, I think, is from someone who may have gone away from our earlier discussion and watched your video, JX, although I think you also referred to this earlier. They're asking about the mouse model of epilepsy that you use in your research.
Yep.
And the question specifically is there a straight epilepsy mouse model, and how good is it for epilepsy research?
So that's an interesting question. So I don't think there's a straight epilepsy model. There's many different models of epilepsy for different types of epilepsy, in both mouse and rats. So whether they are good, whether it is a good model, which is reflecting human epilepsy. So I think there's actually three main criteria that we look at in the mouse model. So first of all, we want to see whether the cause of the epilepsy is it similar to what's in the humans. So so that's in the perfect model. So you have a same cause. So it's the thing that causes epilepsy in human is the same cause in the mouse. And then the second criteria is the phenotype, or we call it. I mean, how the disease is being expressed out in the mouse. It has to be similar to human. So for example, like the mouse model have this shows some spike and wave in the EEG, or when the behavior, the seizure behavior is similar to the human one. So that will be a good model. And the last criteria, which is a more important one, is does the drugs that we know that treats human epilepsy will do the same thing to the mouse. So for example, if this drug is really, it's a control, we know it works for human, but if we try on the mouse, it doesn't work at all. So then we know that this is actually not a good model for epilepsy for this particular study. So we might need to change a different mouse model to fit. So I think there's many different models and depending on different type of epilepsy, and we can, I mean, depending on what sort of study we want to study, and we will find the strain that's more more appropriate, like for either temporal epilepsy, temporal lobe epilepsy model, or say a focal epilepsy model, just depending on the strain.
Okay.
Yeah.
Fantastic. Going back again to something we discussed at the start in terms of risk factors for epilepsy, I think it was you, Lucy, who mentioned about traumatic brain injuries.
Mm-hmm.
One of the next questions we have here is there a difference between the seizures experienced post-traumatic brain injury as opposed to those non-TBI related epilepsy?
Again, this is a yes and no question. It really depends on the kind of epilepsy that we're talking about for being non-TBI, as it were. So post-TBI epilepsies almost always are a kind of focal epilepsy where there's been damage to the brain that's caused some kind of structural problem. So in that way, it's the same as a structural epilepsy where there's some kind of abnormality in the brain that is causing the seizures. And so these kinds of epilepsies are characterized by a kind of seizure called a complex partial seizure, most commonly. And so in that respect, post-TBI epilepsy is the same in that you will get a focal epilepsy and focal seizures, but it's not going to be the same as, say, someone who has childhood absence epilepsy, who has absence seizures, because that is a generalized epilepsy. So within the bounds of all of the different epilepsies that there are, and a vague or a broad categorization of generalized and focal epilepsies, then yes, TBI, post-TBI epilepsies are very much the same as other focal epilepsies.
Okay. In relation to the impact on speech and vocalization, does epilepsy have a long-term effect?
Not as far as I'm aware, Chris.
Not normally. In general, if epilepsy is well controlled, then in general it will not have any long-term neurological deficits. However, there are some exceptions to this, unfortunately. So, especially with some of the very severe types of childhood epilepsy, there's a particular type that's particularly insidious, where the children have seizures at night, and their brains are constantly seizing, and you'll find that they unfortunately will develop severe cognitive deficits, including language areas after that. And there are some inherited forms of epilepsy as well that will cause cognitive decline. Dravet syndrome being perhaps the most notable form. So, in general, epilepsy is a transient dysfunction of the brain and doesn't leave any permanent problems. But there are these exceptionally bad types that can.
Okay, thank you very much. We might just finish off with maybe one or two more questions before finishing for the evening, because I think we've already been going about 35 minutes. I might take one last question that's been submitted online for us. The question here, and I'll read it because it's a little bit long. In the epilepsy community, I've come across a group of parents whose children's daily seizures stop or reduce dramatically when they are sick with virus or fevers. I wondered if there is any research on why this happens. I had a thought about the ketosis effect of not eating due to fevers, etc., but I thought there must be more to it. Thank you in advance.
It's a very tricky one. So I know, I only just found this out a few weeks ago. There's a particular kind of epilepsy which is called MEAK, M-E-A-K, which is myoclonic epilepsy associated with KCNC or something like that. Some kind of potassium channel. And that is a particular kind of genetic epilepsy characterized by monoclonic seizures that does seem to have this component where the children get a fever and they don't have any seizures, and it's something to do with the raising of their core body temperature. And again, this is something that the guys out of the Austin, I think the lady's name is Kay Oliver, who does that work. They're researching this as an area, but like, as far as the cause or the underlying mechanism that suppresses the seizures when the children have a fever, I don't know. Got any insights, Chris?
Well, the only thing I thought of was that, in fact, it's often the opposite way around. That one of the original observations is with fevers, especially with young children, you get febrile convulsions. And the tendency is when you've got an abnormality in the nervous system due to a genetic cause, in particular, the threshold for seizures to occur generally decreases. The temperature at which these seizures will occur goes down, so that sometimes you see seizures in children who have fevers. Having said all that, I'm not aware of that phenomenon, and although I don't do any pediatrics these days, so I wouldn't be aware if I saw it. I wouldn't have the occasion to come across it. But I think that the hypothesis, if it was a general observation, then certainly the hypothesis that it might be ketosis related would certainly be further investigation.
Okay. And we might make this the last question then. There are actually two questions here which relate to things that people can do themselves to, I guess, help manage their epilepsy. And I might combine the two of them. The first one is I have to keep a seizure diary. Is there an app or a best way of doing this so that I can discuss my health with my doctor when I see him? And following on from that, is there any or are there any brain training or other brain exercises that have any effect on epilepsy?
You've asked a person who's not into apps.
Oh, okay.
My answer would be I'd be extremely surprised if it wasn't an app for the season.
Yes.
But I do want to say one thing, and that is that one of my aphorisms is it's very hard to go past a piece of paper. And so a well-ruled A4 sheet with a month on it with writing down exactly what happened is extremely useful. And even perhaps when you're going to a medical appointment, rather than you get the iPhone and I'm not quite sure what it means, but whereas a piece of paper is very instructive, I find. So that would be my contribution, my Luddite contribution.
Yes, well, there are, as Chris intimated, many apps. I had a quick look this afternoon, and there is one that looks like it's really good. It's from the Epilepsy Society based in the UK. And yeah, it's just a very good app. Has a seizure diary, has medication reminders if you need that, has an area for you to write down your GP's details and who to contact in emergencies. It has like a thing on seizure first aid, all this really awesome information that could be really helpful to someone if you had a seizure, outside of your normal environment, as well as being a good seizure diary for you to discuss with your treating doctors.
Was that an app that you found that could be downloaded from their website? Or
Yeah, so it was on their webpage, and then it just had links to the iPhone, to the Apple Store, and to Google Play. So I think that's something that is freely available. Yeah, it's like the Epilepsy Society is a charity in the UK, so I can't see why it would be paid app. But yeah, that looked like it was really good. But just on the brain training thing, I don't think there's really anything that can kind of prevent seizures or prevent epilepsy in that respect.
No, I'm not aware of it. The other thing I would say is that there is a relationship between stress, anxiety, and seizure frequency. We've demonstrated that in both humans, obviously, but also animal models. And so it is conceivable there might be some cognitive exercises that could reduce stress that might have an impact upon seizures, but I'm not aware that they've been formally validated. So I would, and I do occasionally have patients who prefer to use some sort of meditation or some sort of relaxation therapy rather than using drugs. And I would say that most of the time they've come back and we have to use drugs, but nonetheless, I think that they may have some potential with investigating.
Just minimise the stress in your life as best you can, but the way that makes you most happy.
Is there some study that shows like environmental enrichment actually also does impact on seizure? So probably not exercise, but just the environment itself, like maybe like make it more enriched in animal model at least. Yeah.
Just being somewhere that you like being, I think.
Okay, well, thank you very much. For those who may want to go away and have a look for the app that Lucy mentioned, we're just looking quickly here while we've been talking. The website for the Epilepsy Society in the UK is www.epilepsysociety.org.uk. I'm not sure, I haven't got a specific area of the website where you might be able to find that information, but I think the easiest way, if you can't track it down yourself, would be either to submit an inquiry through their website or maybe to visit their Facebook page and see if it's referenced there. Obviously, if you still have trouble, you can always contact us here at Brain Translate or on the Melbourne Brain Centre at RMH Facebook page, and we can try and chase up some further information for you as well. Having said all of that, I'm going to bring this evening's discussion to a close. I want to thank the three of you very much for giving up your time this evening. It is greatly appreciated, and as you can see from the communications coming in from those who are watching, they're finding it very beneficial. And I know the response received so far throughout the week has been fantastic, both to the videos and to the research summaries that we've posted. So thank you again. If people who are watching have any questions that they haven't had a chance to submit this evening, if they're watching the replay of this event, please feel free to still send them through, and we can try and chase up some answers for you in the next day or two or early next week. There are questions that we haven't got to tonight, so if your question hasn't been answered, apologies, but I think in the time we've had available, we've covered a fantastic amount. So again, thank you to the three of you, and that's it for this evening.